starting point for us. And I'm going to talk a little bit about specifically sort of the comorbidity. I wanted to kind of highlight some of the challenges from a health plan perspective in managing sort of the both physical and mental health. This is relatively new for most of the health plans, managed care plan, prior to the Affordable Care Act, which started last year, January 2014, as most of you, I assume, aware of. Most of the managed care plan didn't cover behavioral health. So for us, this is a learning, there's a lot of steep learning, but at the same time, it's a system where it continues to evolve, and what we're really focusing on right now is the integration. So I'll talk a little bit about that. And then, given that we're targeting, our special topic is homeless population, so I wanted to share with you a little bit about what Ellicare is doing, as well as share with you some tips about what I consider as maybe some ways to interact with or help people with severe mental illness. And then the second half of the portion of the presentation will focus primarily talking about the system. I want to make sure that I have kind of a walkthrough to make sure that we understand, the system of care for Medi-Cal as well as our other line of business. So that's kind of the goal of the presentation. So like I said, I wanted to start off by talking a little bit about just sort of the behavioral health needs. This is a fact that actually I've seen variation. Some studies or some sites have talked about 1 in 4, but regardless, if you think about it, 1 in 4, 1 in 5, that's a pretty significant number anyway. Adults experience a mental health illness. Almost half of all Americans will develop a mental illness during their lifetime, and 27% for substance abuse disorder during their lifetime. The fourth one is really sort of the one that I wanted to point out here on this slide, which is that approximately 1 in 25 adults in the U.S. experience serious mental illness in a given year, and that interfere with major life activities. And that's always used, it's like a barometer that we gauge, right? So it's not so much that whether someone has a serious mental illness, but also how is it affecting them. So this is what we call the functional impairment level. And later on, I'll talk a little bit about the system approach and how do we assess someone from that perspective and where to get services, because a lot, it really depends on their functional level. So, but when we talk about limits of major life activities, obviously we all know work, school, family, housing, relationship, all of those, what we consider major life activities. Okay. By the way, the slides are in the handout, the packet that I gave you, so just in case that you want to reference the slides. In terms of diagnosis, the 2 most common mental illness in our population in the U.S. are, I think, pretty obvious to most people, depression and anxiety. Those are the 2 top disorders that in the general populations. And 6.9 of adults in the U.S. have at least 1 major depressive episode. And anxiety is actually a little bit even more common. And remember that anxiety disorder covers a variety of different diagnoses, right? You have PTSD, you could have obsessive compulsive disorder, you have general anxieties. So that's one of the reasons why that statistics is a little higher, because it actually covers several different types of diagnoses. Okay? And mood disorder, such as depression, are the 3rd most common cause of hospitalization in the U.S. Comorbidity, that's the part where I wanted to emphasize a little bit more, because it's a health plan. As I said, historically we manage the physical health piece, and mental health really hasn't been the focus for many of us, the managed care plan. So with the Affordable Care Act, we really start to look at how do we integrate. And why do we want to do that? Because if you look at some of the statistics here, in 2011, for example, 34 million adults in the U.S. has had comorbid mental and medical conditions. That's just a staggering number. Yes?
I'm sorry, what is comorbid?
Okay, so comorbid means that they have it at the same time. Right? So these are the folks that typically have a mental health problem as well as a physical health problem. So when they are happening at the same time together. So what are some of the special needs, right? So historically, what we talked a lot about, the system is very kind of a silo. So, you know, you have someone who has a physical health need, they go see their doctor, right, their PCP. And then if they have mental health needs, maybe they go to the county to get services at clinics or whatever. And they are very separated, right? The two systems really don't talk to each other. One of the advantages, obviously, now that LA Care cover mental health services is that now, as a health plan, we have both information, right? We have both information about when our members accessing mental health services, and we also have information when our members access physical health issues, have physical health issues. So as a health plan, we need to look and see how can we use that information to help our members, right? Because we know that some of them interact with these two issues. These issues are not isolated. So, for example, if you look at the third bullet point, it says that individuals with mental illness are more likely to have health risk factors such as smoking and obesity, which increase the likelihood of chronic medical conditions. So now this particular point really highlights that bi-directional relationship, right? So this is not a one-way effect. This is an effect that kind of affect each other. So you have someone with mental illness who's going to increase have higher risk for certain things, and then in effect, it's affect their medical conditions, and then which affect their mental health. So that's exactly what I'm trying to, the first bullet point. A physical condition may exacerbate a mental health condition, while a mental health condition may hinder treatment for a physical ailment. Okay? And the second bullet point is really an example, if you think about it. For example, we know that those people who are depressed are more likely to be non-compliant to treatment. Okay? So imagine that if they're non-compliant, let's say to take their antidepressants, or non-compliant, not going to their therapy, to get therapy. Can you imagine, what if they also have a chronic condition, such as diabetes, hypertension, and they need to stay on those medications in order to make sure that they're stable? If they don't take those medications, their physical health will also be affected as well, right? So let's say, so if the PCP is not aware that the member have a depression diagnosis, not aware that the member is struggling to stay compliant, then the PCP is not going to know whether this member is also taking her or his or her medications for the medical conditions as well. Okay. The last bullet point, I think, is probably the most salient or the most impactful point regarding this comorbidity of mental health and physical health, is that individuals with serious mental illness die on average 25 years earlier than the general populations. And we know that the reason is not because of the mental illness. Mental illness alone doesn't lower your life expectancy. It is the physical health condition. So it's because they're more likely to neglect, to not pay attention to the physical health. That's why their life expectancy is much lower. Okay? All right, questions so far about just sort of some general behavioral health facts, as well as sort of the idea of comorbidity and the kind of the relationship, connection between mental health and physical health. All right, so moving along then, I wanted to spend a little bit of time to talk about mental illness and homelessness. And again, I think you guys on the ground, I'm sure you probably have a lot of stories and experience to really do share with me, but I'm hoping that I'll give you some kind of broad kind of overview as well to kind of shape the discussion. Again, the first fact, actually, I've seen variations about it, 1 in 4, 1 in 3 I've seen. But about 1 in 4 homeless persons struggle with severe mental illness, and that's really been talked about for years now. And with the deinstitutionalization, you can point out to a lot of reasons. but we know this is the fact. About 150 to 200,000 chronically homeless individuals nationwide use more than 50% of services. And service, when I talk about services, I talk about health, general, any kind of services, health services, any kind of support services. So, but the point is that you can highlight the amount of resources that we channel, we have to funnel to help this group is tremendous. Of course, there's numbers on veteran as well. 131,000 veterans are homeless on a given night. And many of them, again, live with mental illness. I'm going to jump to the last bullet point here. The lack of housing causes people with serious mental illness to cycle among hospitals, shelters, streets, and jails. I don't know about you guys seen this. I certainly, in my days working in inpatient psychiatric facility, have seen a fair number of these type of scenarios where, because for homeless populations to, at sometimes, that's one way to kind of really get a roof over their head, to go to emergency, departments, and to just try to be able to, get a warm meal, and you see that happen a lot. So again, I don't know, you guys have seen that yourself? Yeah, I think this is quite quite a challenge. So some of the key factors in how we can address homeless people with mental illness. And when I was looking through, kind of try to see, okay, what can I put in here? I realized that to some extent, there's not a lot. There's a lot of overlap. This is how you would deal with, anyone to a great extent, not just homeless people with mental illness, but maybe general and homeless, well, general anyone, right? But when I was thinking through this, and as I was trying to find some, really helpful information, I think these 3 points are, to me, still relevant, still much a key to success. First, it has to do with respect. I think that a lot of the time, people who are struggling with both mental illness and homelessness in general really feel like they're not being respected, right? Because they're asking for these sort of handouts, and it's, I think the circumstances make them already kind of difficult. So as a frontline staff, as someone who interface and work with these folks, I think it's really important that we really show respect, right, regardless of their circumstances. Okay, I think that's an important message. The second thing is that as I was again researching and looking to see, some ideas, it's housing options. I think that's as an inpatient psychologist working with some of the homeless folks in the past, I've noticed one of the challenges is that there are just very limited options out there, right? And a lot of the times you can't really find, we try to kind of fit someone into a certain mold because everybody sort of look for different things. So I think it's really important that if there are options, we offer options for them and really listen to their needs. And ultimately, you may not be able to find something exactly what they're looking for, right? But at the same time, I think it's good to discuss options. Nobody really likes to be just say, well, okay, well, you go here. You just kind of, you just say, okay, this is all you got. So I think if possible, if you can offer option and also try to find out what their needs are and then see how it can best fit. Your options may be able to meet some of their needs. I think it goes a long way to help them to accept the help. And the third idea has to do with secure treatment. I think it's really important that we provide that linkage. Often when you're transitioning from, say, again, using my own experience working in inpatient, you know, how do you secure treatment? How do you connect someone to a follow-up care? And how does that make it available? But not only that you have to have an appointment, right? You kind of think about how do they get from A to B? How do you get to the appointment? Right? Is it convenience? Is it the time? Is it the location? Is it a new facility? So many things that you have to think about when you, so it's not just about making an appointment, having an appointment, but there's so many other steps that we have to think about to really walk through to make sure that you have a successful linkage. So those are some of the things that beyond just, you know, an appointment.
I think you probably just defined what most of their days are like. All of those struggles right there. Yeah.
Right. So, you know, I hope that this kind of reinforce, I think, some of what you guys do on a day-to-day basis and how important it is. As I was, you know, again chatting with Leslie, you know, for us as a health plan and for myself, you know, I'm like a couple steps removed from sort of the facing the members, the clients. So sometimes it's a challenge even for us to really recognize what are the challenges. So, and it's important for us to have opportunities to hear sort of feedbacks about how, as a health plan, that we can make it easier for you guys, right, to help our members. So keep that in mind. I'm hoping that maybe if you have any questions related to that, we have a chance to kind of talk as well. Overcome previous bad experience and that they have with shelters and support programs. And I hear that a lot, again, in my old days working at inpatient. A lot of people, folks that don't want to go to shelter, don't want to go to this housing or that housing is because of a lot of bad experience. And it is very difficult to overcome that because one bad experience can really stay with that person. And how do you convince them to try it again? How do you help them to think that, hey, maybe this time it's going to be different? And overcoming that, I think, is really important. And I think that's when, you know, building that relationship and rapport can help that person to maybe overcome that. A couple other points, and I kind of assume that maybe a lot of you have heard of these contingent management program to reduce substance abuse, particularly there are models out there that looks at using this, what we call contingency management, meaning that if you follow these steps, then you'll be able to receive, you know, kind of like a token economy. So that's particularly helpful with people who are trying to help them to stay sober and sobriety. Although a lot of people will say that the goal is not necessarily kind of complete sobriety because it's difficult. So it's going to be very challenging. But what you may want to look for is a reduction, right? So even a reduction, a step in the right direction, could be a way for you to offer whatever additional sort of supports and help that you can provide. And the goal is to help the persons to get to you know, take that small steps. So that's what contingent management programs is focused on. And the housing first model, most people are kind of familiar with that, right? So the focus is really, you know, housing is a priority. So it's not about, you know, we know for many years now that, you know, yes, there are many needs for these folks, but if you don't put them in a permanent housing, you know, you're not going to get a lot of success. So we want to make sure that, and so we very much as a health plan really advocate for that. So one of the things that we're doing in collaboration with the Corporation of Supportive Housing is that LA Care actually offered a grant to CSH. And in September 2014, we awarded the grant to CSH to provide an on-the-ground intensive care management services to reduce rehospitalization rate among what we call the highest need, highest cost LA Care members and who are homeless. Anybody know a little bit about what CSH does in general and about this particular project? So what
This
we're
is
doing.
Fuse, right?
What's
Is
that?
this the Fuse
yeah,
project?
The
You
Fuse
guys
project.
familiar with
So
Fuse?
this is part of their Fuse program. And what we do, how we come in LA Care, at LA Care is that we're assisting CSH in identifying those folks, okay? So what we look for, our target populations are our our CalMediConnect members who are also homeless and have frequent hospitalization. So we've been partnering up with CSH. What we're doing is we're helping them to identify those folks. So we look at because as a health plan, we have all those records, right? We have the claims, we have information about how often someone's get hospitalized. And we find those target folks, and then we link them to CSH, and they provide that intensive care, case management. The outcome of the goal is to really reduce sort of that cycle of chronic homelessness and stop repeated use of hospital emergency room. And those are you can imagine, those are the most expensive services, right? At emergency, inpatient. So we recognize that there are a lot of space for LA Care to really provide some support to the community, to organizations. So this is just one example of what we're trying to do to help our homeless member.
I think CSH may contract with some of the agencies like PATH and some of the others to deliver some of that care through Fuse.
Right.
As I understand it, they connect with some of the agencies to do that.
Right. And so, because we're partnering with CSH directly, and so we have
and then
these regular
CSH,
meetings actually to help them to kind of identify sort of the members. We actually have a list of target hospitals. In LA there are like 75 general acute facilities, so so just you kind of have to narrow it somehow. So actually, we target certain region and certain geographical areas, and we have a small list of hospitals that we focus on, because not only that we have to, there's that intensive case management, but we also have to work with the facilities, the hospitals, because as these members come to the facility, we want to make sure that they get connected right away. They get case management right away. So it's very difficult because a lot of the time these hospital visits are very short, right? So they could be like a day, 2 days, 3 days, and then boom, they're out. So they cycle a lot, but at the same time, they come back all the time. So we also work with the facility, the hospital, so that they also flag these members so that when they come in, they immediately kind of be able to connect back to the intensive case management program, so that activate the service, and so you can intervene, you can help right away, and link the member to ultimately, obviously, to housing, because we think that's how you're going to stabilize the member. So housing is the key for that population as well. All right, so all right, tips. So this is the one where I thought, okay, I wanted to outline some tips for you, but at the same time, I realized that I'm not going to be able to include everything. So these are meant to be just sort of, just something for all of us to kind of think about, but I always think that each client is unique, and you kind of have to come up with a unique way to really connect. The ultimate goal is really to build that rapport, to connect with that person so that that person can receive whatever you have to offer, right? Because if you don't have that connection, if you don't build that rapport, you can have all you can offer, you can have great things to offer them, they're not going to take it, they're not going to receive it. So some ideas, you want to be obviously straightforward and brief, sometimes communicating with folks who have severe mental illness, especially with schizophrenia or paranoia, simple, straightforward way of communication. Way of communicating is really the best way. I try to stay away from arguing. Okay, so it doesn't really get you anywhere. So kind of stay away from that. Move person away from cause of fear. That's really more about when you're dealing with someone who does have a paranoia or paranoid delusions. right? So sometimes it's not piggyback on that, not arguing. You don't want to challenge. You don't want to say like, well, where is it? I can't see it. You don't do that, right? Instead, what you do is you try to just change to different topics, and well, let's come over here, right? So what's the difference between talking over here or talking over there or different location? It doesn't really affect how you can help that person, but it does shows that you understand and that you recognize it, and you're not there to necessarily correct them, help them see that, oh, well, there's nothing to be fearful about. That's not the goal. So giving enough personal space, okay, so that's always something that I'm mindful of, because that personal space can be different from person to person, especially in my mind, someone who's out on the street, they're maybe even more sensitive to their personal space. So I think that's something to be mindful of. Call for help if someone is in danger, that's pretty obvious. Focus on what's real. Again, when you're dealing with someone with paranoia, it really doesn't get you anywhere if you just kind of trying to just engage them to talk about something that you believe it's probably not real. Okay, so focus on what's real, and I think you find a much more you have better sort of success in engaging. And tell the person what you're going to do before you do it. And I always try to be very conscientious or kind of think about this particular one, because sometimes I don't want people to misinterpret my actions, and sometimes what we consider as a social norm, maybe they have a different perspective. So I don't make assumptions that they understood what I'm about to do, what I'm about to say. So often it might not be a bad idea to just kind of explain and say, okay, I'm about to walk you to, I'm going to show you something that really kind of help to kind of set the stage a little bit, so that they have some expectation, so they don't consider, that you are not communicating, and that you are not understanding what they're coming from. So again, these are just some general tips. Maybe at this point, do you have any sort of your own idea or challenges that you wanted to share or think about? I don't know if these are something that you can sort of take with you. I hope that it kind of helps you a little bit about kind of put some kind of framework as to how you might help your clients. Questions, comments? Yes.
I have a challenge with the lady who does have a mental illness.
Yeah.
She doesn't identify.
Ah.
So to house her, and in her previous housing, she was evicted because of mental health related things she did. And now they're saying, okay, Alicia, we need her to address this before we house her again, but she doesn't identify. So
right.
I can't force her to,
Right.
So I'm having a problem housing her. They can't force her to
Bless you.
So, without knowing too much of the case, but one of the thought that I have is that sometimes, maybe as simple as not having, focusing on behavior, actions, rather than the label, because we all know how, label can have a lot of sort of negative sort of effect on someone. So does it matter if someone truly say like, I have schizophrenia or I have bipolar, as long as if they are whatever behavior that caused them to lose the housing, if they can modify, if you can work with them on changing that behavior, that might be it. And part of it would also to educate, right, the other side and say, hey, I'm not really, maybe the focus is not really that the person has to come up and say like, I accept my mental illness, I know I have schizophrenia, I have this, but really, because what you're looking for is a change in behavior. Can we work this way? And I think that The other part is that you can utilize some what we call sort of motivational interviewing techniques, such as you wanted to maybe focus on their goal, right? So a lot of times when we talk about recovery-based kind of treatment, we talk about, okay, can we talk to the member or the client, your client, and find out what is their motivation? So if they are motivated to, say, get housing, so can we use that as a way to kind of lead them, to kind of guide them to achieving that, maybe by modifying some of their behaviors? Again, it's really important that we want the clients to see that we're not forcing them to, because I think there's this really resistance, right? Kind of like sort of defensiveness about it, and saying like, well, no, I don't want to do this, right? The resistance, or the labeling, right? She doesn't want to be labeled, right? So let's move away from that, because ultimately success is not about, in my mind, not about someone who just like, okay, well, I have this.
Right.
It's what do you do, right? So if we can move away from that, maybe kind of get her or him, her closer, a little bit closer to achieving the goal. Yeah. Thank you. Okay. So any other thoughts? Okay. So so this anybody have the time?
It's about 20.
Oh, there it is.
23 yes, yeah.
Okay, good. Okay, so this is sort of the second half of the presentation. Now I wanted to kind of cover sort of the system of care, so just to make sure that everybody sort of understands sort of what's the latest in behavioral health services. So behavioral health benefits and services, as I mentioned already, it started January 1st. The managed care covers behavioral health benefits. When we use the term behavioral health, I think probably most of you are aware that it actually covers mental health services as well as substance use. That's how the term behavioral health is being used. Sometimes we get the question, what's the difference between behavioral health and mental health? And that's meant to illustrate that. Here, this slide actually, it's pretty small in your print, but there is another handout in the folder that looks like this. It's a little bit better to read. It still probably tests your vision a little bit. Hopefully you can read this well enough. So this is meant to show sort of the landscape of behavioral health services. On the far left column, it says PPG, PCP. That's basically, PPG is our physician group. So in managed care, in healthcare, each of our member is assigned to a physician group, okay? And then within the physician group, our member get assigned to a primary care physician. And that's how kind of the healthcare structure, how it works for managed care. So the first column is really meant to be for our physician group, our PCP. So from our standpoint, if someone truly have a very mild level of mental illness or impairment, really a lot of the services can be done at the PCP level, such as routine screening for emotional health and substance use. The routine screening, there's a, I gave you guys actually an example. This form here in your packet, this is a form that we actually distributed to all our physicians group and our physicians, is to help them, because not all, let's face it, not all primary care physicians are comfortable talking about mental health, right? So this particular form are meant for our physician to really talk to the member and screen for the two top disorder, depression and anxiety, as well as alcohol, potential alcohol misuse, okay? So that's the routine screening, obviously medications, outpatient medication. Even for our PCP, some of them might be comfortable with a little bit of support, education, kind of using the word counseling a little loosely, okay? This one, screening, brief intervention, and referral for treatment, is relatively new benefit for Medi-Cal. Is actually to help to screen for members with potential alcohol misuse problem. So if they if the member identify that they potentially have an alcohol problem, then the physician actually will do an extended screening, potentially give a brief intervention, or refer the member for treatment. And for someone who's under 18 and might have some developmental issues, physicians also does a lot of referrals to regional centers. And so that's sort of at the mild end of the spectrum, right? So, and the middle column is what LA Care offered, and that's something that did not exist prior to Affordable Care Act. Okay, so this column did not exist at all. So you can see, visually, you can see that there was a gap, and so we're filling that gap right now. So, and I'll talk a little bit more about these services, but they, just for now in this chart, the key is outpatient services. So these are office-based. So just think about like someone who show up at the doctor's office on a weekly basis, whether it's therapy or maybe medication management, those type of level of services. Nothing has really changed. I assume that most of you are familiar with the county specialty mental health. This is the column that represents the county level services, and nothing has changed since the Affordable Care Act for the county level services. And then the last column here is for substance abuse. And there are actually some changes in the horizon for substance abuse, specifically for those with Medi-Cal, because Center for Medicare and Medicaid have just approved, like maybe about a month ago, approved California's drug Medi-Cal waiver program. So right now, drug Medi-Cal is a little bit disjointed. You know, of course, LA County tried to organize it, provide services linkage, but CMS just recently approved our California's application for the waiver program, which means that drug Medi-Cal is going to evolve and move to more like a managed care program, which means that for those with Medi-Cal, if they need substance abuse treatment, they will have access to service similar to how they would have access like with us as LA Care. So they can call the 800 number, they'll triage them, they'll point them to the services, they'll link to the services. So it's much more organized, it's going to be much more efficient and have much higher ability for access. So a lot of good things are coming under drug Medi-Cal. So
my question is how
yeah.
long?
Yeah.
And the reason I bring that up is
Yeah.
because, you know, we have such a very small window
yes.
when a client presents to
Yes.
us and says,
Yes.
you know, I'm ready for treatment,
Yes.
I want to get sober, I want this to fix.
Oh yes.
And there's no beds.
Yeah.
You know, you might keep them on the hook for a while, calling every day, looking for a bed, pretty soon they're like, off and using
All right,
again.
bye-bye, yeah, right.
Yeah.
So this meant to address that. So it's going to be under the LA County Department of Public Health, the SAPC, the Substance Abuse and Prevention Control Division. So they are in the process now, actively engaging with stakeholders. They have stakeholder meeting. So I believe that sometime next year, I want to say by mid-year, they want to have the system, everything in place to start the process. So it is exactly one of the design of this waiver program is to address that particular question, because we know that for substance abuse, timing is so critical, because most substance abuse, unlike mental health services where you actually can have someone go through conservatorship and there's a path where you can have someone be conserved to get treatment. Substance abuse, there's no such thing. Okay, so if you're dealing with substance abuse treatment, the person has to be voluntary, engaging, willing, right? So so that is a key component of success for linking someone to substance abuse treatment. So the new drug Medi-Cal waiver program is hopefully going to be able to address that. So for example, when you triage somebody, they're going to be able to, so they're actually building what they call like a network, just like healthcare, right? So they have a network of substance abuse treatment provider, and then they're going to be able to link them. So, so that's a lot of changes coming up for Drug Medi-Cal. Especially mental health services, I'm not going to spend a lot of time talking about it because, again, I believe that all of you are very familiar with it. Nothing has changed. This table just meant to kind of show you how DMA kind of structure the level of needs, and depending on the level of needs, how you, and the indicators and this decision and who to contact. So I thought this is a pretty handy. I don't know if you've seen a similar table before, but this can be very handy as well. The non-specialty. This is again the LA Care, what LA Care covered now. So those are the services: individual and group psychotherapy, psych testing, outpatient services for the purpose of monitoring medication and treatment. That third one is basically going to see a psychiatrist to, to fill their medications, to make sure that there are no issue with side effects, and so forth. Lab medication supply supplements, that's just to indicate as obviously some medications require, blood drawn, lab works, those kind of things. And psych consultation. This is how we, LA Care, actually contract with a behavioral health organization called Beacon Health Options. They used to be called Beacon Health Strategies. Anybody heard of them before? Beacon? So it's a private company that basically have a big network of mental health providers. Again, think of those that have office space, right? So just private, providers. And we contract with this particular company, Beacon, to provide all of these services. So when our member called this number, Beacon managed to call this phone line. And on the phone, the Beacon have a licensed clinician that talk to the member and do a brief screening to make sure that member is appropriate for this level of service. Okay? Once that's done, and what happened is that the Beacon will provide a member with several names of providers, and they just need to call and schedule an appointment, and that's it. So this is this level of service where it does not require a referral. It does not need the PCP to, typically if you think of managed health plan, HMO, typically a lot of specialists, you need a referral from the physicians. For behavioral health, you don't need that. So it's as simple as just directing a member to just call this number. Now, if you have someone who may have difficulty navigating, you can stay on the phone with that member. That's okay. You can help them, assist them in navigating the phone call. That's not a problem. Sometimes some physician might even want to call with the member. So it really depends. But that's how members access LA Care level benefits. Questions? Yeah.
So just to be clear, so they access it through their PCP, who might make a referral to Beacon too, or through a phone call to Beacon?
So the way kind of the flow would be, let's say if the PCP did a little screening, right? So they went to do their annual checkup, or they're at the PCP, they did PCP did the screening and identified that the members actually do have some mental health issues, want to refer the member to behavioral health. The PCP can be as simple as, here is a phone number. You can just call Beacon and tell them that you saw me and there's no authorization. In the healthcare world, there's a term called authorizations, right? So, if it's something that you can't get until you get authorized, so there's no authorization for behavioral health services, right? So that's how typically a PCP might refer someone. Or, again, doesn't have to be through PCP, like for you guys. If you have a client who you felt like may need to be connected to behavioral health services, doesn't seem like the issues is very significant that need county level services, You can just direct the member, hey, I heard that, you know, I know that LA Care covers behavioral health. Why don't you call this number? You'll be able to talk to someone on the phone. They'll kind of find out a little bit about what's going on, what you're going through. They'll be able to kind of direct you to some services. That's it. So you don't, that could be as simple as that as well. Again, yes.
So when you're saying below county level services, meaning that they actually,
Yeah.
what the services that they need are less than what Department of Mental Health
Correct.
would take on as a patient, so they're not, they don't have the severe and persistent mental illness
Exactly.
category that. But if they have that, but they don't want any part of it.
So, there, which I know that happens too. So what we typically have a policy is of no wrong door. So that could be that scenario, or it could be a scenario actually that maybe they initially didn't disclose quite as much, right? Because this is difficult. Can you imagine talking to someone, a stranger on the phone, telling them all about what your problems are? So it is not unusual to also someone to call the number and not disclosing everything that's going on. And so maybe the initial screening evaluations, okay, well, you know, this is not at the DMH level of services. So we'll assign you, we'll give you a doctor to see, we'll give you a therapist, you go start to see a therapist. And then maybe after a couple sessions, this therapist really then start to recognize that, wow, this is not just someone who can really just come to my office on a weekly basis and be able to get the help that they need. They need wraparound services, case management, they need intensive outpatient. So the therapist can then refer the member to DMH. While this going through the process, the therapist will continue to see the member until the member is successfully linked to DMH. That's what we call the step up. Right? And then sometimes we do step down. So DMH may have a client where they've seen for several years, and the member is now very stable. They wanted to transition the member to a lower level of care at the LA Care level. Same thing, they'll contact Beacon, DMH will reach out to Beacon. Beacon will start the process, link the member to the service needed. Then DMH once recognize that, oh, the member is now receiving service through LA Care, they can close the case with DMH. So that's what the level of communications that require the behavioral health system to work. Because of the fact that we have a bifurcated system, right? So we have the county level, we have the health plan level, but people just don't stay at one level, they're movement. So we need to work very closely with our county folks to make sure that people who need the move from one system to another, we have an efficient and effective way to do that. But, and one of that would be to tackle the issues of challenges. Sometimes people just didn't want to go to the county. Maybe they'll but sometimes we may want to just get some service, right?
So would that be like, so depression, anxiety, would PTSD, like what would allow them to stay with LA Care if they didn't want to go to DMH?
So what we try to emphasize is that we try not to focus too much on the diagnosis, because the LA Care covered benefit is inclusive. So any diagnosis can potentially receive behavioral health services through LA Care. What is the key, again, is the level. So if you look at it again, this continuum, think of this as a continuum. So this is what we call the mild level, and this will be maybe more to the severe level, right? So what it can constitute mild to moderate to severe is not the diagnosis per se, because we've seen it, I think I've seen it, that people with diagnosis of schizophrenia, bipolar, but they can hold a job, they have stable housing, they go to the doctors every month to fill the prescription, they are managing very well in terms of their symptoms. They don't necessarily need DMH level services. We're talking about just managing the medication. Maybe we can talk about just even therapy on a weekly basis, to supportive therapy, just to make sure that the persons have that support. It's perfectly fine for LA Care to provide that service. So, I try to kind of not focus too much on the diagnosis, but really think about their functional level. It's still a little, obviously it's a little gray, and that's where the other thing in your handout is that there is a universal kind of behavioral health screening form. It looks like this. This is actually a screening form that LA Care, HealthNet, all the big, all the different key players, stakeholders, and DMH work together to improve and to change, to modify. So now this is a kind of like a universal screening form, and that allows you to kind of give a sense of where this person might best receive services. And all different agencies will accept this as a sort of a screening, this particular screen. So we work very closely with our partners, again, with DMH, with HealthNet, with all our healthcare partners, to make sure that we are all on the same page when it comes to sort of the level. Does it help the explaining some of that, your question?
Mm-hmm.
Okay, great. So in the interest of time, I just want to make sure that I can, this is just a referral form, this is the screening form. I kind of blow up that midsection here because this is how you can kind of determine, in a very kind of basic but crude way of looking at if it meets urgent criteria, routine, or health plan level, that's LA Care level, or just substance use disorder only. So I think I'm going to see if I can move along. I have a slide that talked a little bit about HIPAA, but you can take a look. Yes?
Wow.
Quick question, the Beacon Health Office referral form, is that available on their website as well?
Yes.
Okay, sometimes it's kind of hard to navigate the
Yes.
website, so I.
Yes, that form, it's kind of interesting that, like, I put it there, but technically, you don't need a form. So it's one of those things that, okay, should I have a form? Should I complete a form? It's there just for your reference. So they might ask you on the phone for some of those information.
Yeah, sometimes.
Okay, but you don't. But if you need to refer someone to Beacon Health Options, you don't need to find that form before you can refer. Okay, so that's the bottom line.
Mm-hmm.
They can just call.
So does that mean too that the physician doesn't have to screen?
All right, so this is the lowdown. So, this form is also meant to be for the physicians or anyone to fill. But the reality is that sometimes physicians don't really like to fill complicated forms. So what the physician does is they fill this top part and then they leave out all the critical information that you want and they just refer. So that Beacon form is actually created based on that. So in reality, what we want to make sure is that ultimately we don't want these because the physician doesn't want to fill a form, it's too complicated to be barriers.
Mm-hmm.
So just remember these forms are meant, in a perfect world, we want them to fill out the form so that we have the information, you do proper screening so that we can kind of direct the members to the right place. But ultimately, right, I think for you guys too, I'm sure that you want to eliminate any barriers. We don't want forms to be the barriers. We don't want any of these sort of administrative steps that be barriers for people to access service. So ultimately, if you want to link someone, you can call.
Wow.
And and then everything can be taken care of.
That's great.
Okay. But the helpful part of screening is that we don't want the member to be directed to this and then go, oh, well, you don't really fit here, you go here, and then, you kind of zigzag around and call many different places to finally land at the right place. So these forms are meant, obviously, to provide that screening so that you can also kind of get a gauge as to where this member can best receive services. This slide also kind of matches, there's this handout here that talks about LA Care Behavioral Health Department support line. This is not, we try to emphasize this is not for our members, so please don't give out this number or this email address to a member because it's managed by our staff. We have a total of about 1.8 million members in LA Care. So our staff cannot answer questions fast enough. But these are really good for you guys, for our providers, if you have any questions. So again, I don't think I can cover everything or that different every scenario. So this is always handy, regardless of what I'm able to answer some of your questions, or maybe something that comes up that I didn't cover. This would be a great resource. It's managed by our behavioral health clinicians at the department and work during work hours. So Monday through Friday, 8 to 5. Okay. These are just some contact information, myself included in there. Our medical director is Dr. Chow. We have some different team members as well. And these are some numbers just for our LA Care department contacts. But if you don't know who to call, you can always just reach the behavioral health department. That could be a good starting point for you guys. And then some resources. So there's a link for LA Care. Sometimes it's hard to navigate our website, but we do have a link that has some forms and toolkits available. And again, our number and our email address. So I managed to squeeze it in an hour, but I'm wondering, I just want to make sure, unfortunately I have to run back to the office, but I do want to maybe in a couple minutes, if you have any questions, comments for me. Yes?
I do have one question. Individuals on an emergency Medi-Cal, do they qualify for these services?
No. So emergency Medi-Cal is for inpatient, for hospital only inpatient. So they have to have full scope Medi-Cal. So inpatient, they're typically not assigned to a health managed care plan at that time. Right? Anybody else? Yes.
I'm working with a member who, I think it happened like twice. He went to the emergency room at Harvard, and they sent him to a different hospital. Do you know why that happened?
Okay, so it depends on, it's an LA Care member? Okay, so my hunch is that it might be one of our product line. It's called CalMedi Connect. I don't know if you guys heard of that. Is the, that also started last year for those who have both Medi-Cal and Medicare. They have an option to join one of the 5 CalMedi Connect plans in the county. LA Care is one of them. So if they have because Medicare is the primary insurance, Medicare have certain coverage that allow LA Care to utilize other facilities. So my hunch is that probably is one of our CalMedi Connect members, and if that's the case, if they go to, say, Harvard UCLA, because Harvard UCLA is not what we call an in-network facility, so we will likely transfer that member from that out-of-network facility to an in-network facility. So that would be my guess. But that's only applicable for our CalMedi Connect and all commercial lines. LA Care also participate in the Covered California, so we actually have we're the only public health plans that participate in the Covered California. So that's considered our commercial line of business. That's also could be the case. But for traditional Medi-Cal members, that person unlikely will be transferred to another facility because it's the responsibility of the county.
Okay.
Yes. Any other questions? Yes.
So I know the system is in process, but in terms of substance abuse, what do LA Care plan members have access to right now?
So drug Medi-Cal is completely carved out, meaning that any drug Medi-Cal benefits are not administered by LA Care. So the way it's worked is that if you have a drug Medi-Cal certified facilities, they actually bill the state directly. So we have very limited substance abuse treatment services. One that I can think of would be what we call medical detox. So detox is obviously one of the ones that a lot of people think about, asked about. So LA Care do cover something called medical detox, which is the scenario when someone is experiencing withdrawal symptoms to the point that they have some physiological, physical health issues. Okay, so in those cases, if they show up at the emergency department, they can get admitted to the general acute facility on a medical floor because of their medical condition associated with the substance use, and they can get detox while they are being treated at the hospital. So that's what we call medical detox, and something that we cover in LA Care. But we don't cover, for example, social detox. We don't cover like residential detox. Those are all part of drug Medi-Cal. So if you have a Medi-Cal member, your options are still going through Department of Public Health, SAPC. They kind of organize it, right? But what I'm saying is that the system is going to improve tremendously. I think that's what we're all very excited about.
Yeah.
I think we're hopeful that by next year, mid-year, I think it can kind of roll out.
And can you say anything about the health homes and how that's developing, or is it too early?
I know a little bit about it. So there are health home and health neighborhood. Health home is more of a state initiative, and I think LA County, the Department of Mental Health is working on a project called the Health Neighborhood, and LA Care is participating with that. The key concept is that there are 6 or 7 areas within the county that DMH is focusing on. What they're trying to do is build what they call the health neighborhood, so that they have a group of physicians as well as mental health providers, and all of these folks are within that one neighborhood, and so that they're connected. So there's one, for example, consent that they need to sign so that they can exchange information, so they can work closely together to provide services. So that's what sort of the broad understanding that I have with the health neighborhood. So for example, LA Care is actively recruiting a lot of our physician groups and our PCP to participate with the county initiative, that health neighborhood, to make sure that we have a sufficient numbers of physicians. So one person will be, the same basically the member who is assigned to that physician is going to, if he or she needs physical mental health needs, will go to this doctor. So they're all like the same group, small group of practitioners that work together with that small group of members.
Great.
And that's the concept of the health neighborhood. Yes.
How many visits can a member get for any therapy when they go through that system?
It is unlimited.
The reason I bring this up is
Yeah.
because I'm gonna say this, we have a lot of our clients
Yeah.
who are attached to DMH, they're not getting individual therapy anymore.
Right. So unfortunately, one of the key is that because the system is set up that they can't really get services at both level. Okay, so DMH, once they move to the LA Care level of services, then they have to be closed at DMH. So that's the only kind of the challenge. But for LA Care benefits, there's no limit per year, there's no, they don't max out after 8 sessions, 9 sessions, whatever. It's all what we call based on medical necessity. So, and that means that there's a general sort of general review process that we do, but if the member continue to benefit from it, they can continue to see it.
Because I could see even some of our more severe people,
Yeah.
if they were getting individualized therapy, would actually fare a lot better
Yeah,
in the
right.
mental health system.
Sure.
Where they will not attend the groups and things like that.
Sure, yeah. Yeah, so that's something to keep in mind for sure, yeah.
If people do call that number
Yeah.
and want to get somebody into treatment,
Mm-hmm.
and what are the options? Say, I mean, a lot of the clients that
Uh-huh.
people serve are in the Skid Row area.
Yes.
Who are they going to be referred to?
So that is, we have certain expectation of our vendor Beacon to provide services based on geographic location. So it's really important. Access is a big piece. So a lot of our members, obviously, here we talk about the homeless population, but a lot of our members have limited means of transportation. So we want to make sure that there are available providers nearby. Okay. So I think one of the challenge for homeless population is that, to some extent, their day-to-day, maybe sometimes they stay in a geographic location, but the reality is that keeping an appointment, remembering the appointment, all of those are barriers, and as well as access, location.
Yeah.
So if you ever encounter members who have these unique, because the system is designed for the majority, right? But we have to have the flexibility to also come up with other creative solutions. So if you have a particular member with those type of challenges and call us, we can problem solve with you, with Beacon, to find the right combination of fit. So whatever it is. So we don't want, so if you wanted to kind of reach out and utilize us that way, that's certainly perfectly fine, because otherwise, you know, especially if you have a member who you say, you know, you're thinking like, okay, just give them a phone number, they're not gonna call, you know, they're not gonna be able to navigate the system, they're not gonna be on the phone, be able to figure out to ask the right questions. Why do that? And then they get frustrated and it's like, oh, I'm not gonna ever do that again. So if you can anticipate some of the challenges, so because remember, this system is set for sort of the general public, general population. If you think that your client's gonna have some challenges, difficulty, unique situations, call us, let us know. You can, again, assist the member in calling. You can call in advance. If you wanted to test it out and call Beacon and say, I want to talk, you know, kind of vet through this scenario before I actually tell my client to call you. I want to have, you know, kind of find out. You can do that as well too. So,
wow.
so think, you know, so I hope that the system that we created is flexible enough that we can accommodate some of these unique challenges. Does that?
Yeah. Yeah, and know that, I mean, most of these guys will go to an appointment with their patients.
Yeah.
They'll make sure that happens, so
Right.
that connection,
Right.
like, know that they can rely on these experts to
Right.
get them there and make sure they're complying
Right.
and all that. That's a really important connection.
Yes, yes. Any other, I'm looking at the clock, just because I kind of have to dash back, but there's, again, our number and email address, so feel free to reach out and contact us if you have any questions.
Thank you so much,
Thank you.
Dr. Poon.
Thank you.
And Dr. Poon put in here, there's also some transportation available, so look at that as
Yes, if you have a
well.
question about transportation, you can let us know too, but we do have a company called Logistic Care that provides that transportation services for our members. So depending on, I think our How Many Connect members have sort of more of the unlimited, where our Medi-Cal members have a little more limited kind of number of trips that you can take. But call us if you have any questions about
Yeah.
that.
Great, thank you.
Thank you so much. Thanks
Thank you.
again. Thanks.
Thanks so much.
You're very welcome. Thank you. Okay.
Yeah,
Sorry again that I have to
Sorry to hold
dash
you
out.
up. Yeah.
Okay.
Thank
All right.
you.
Take care. Bye-bye, everyone. Bye.
Bye. So lunch should be here, guys. So lunch is out here. So let's take 45 minutes and come back at 1. Everything here. Was that helpful, you guys?
Yeah, that's
Was
cool.
that-
Because DMH doesn't give individual therapy.
Yeah, who wants to go there, right?